This video recording is about interpretation of laboratory data. It is part of Pharmaceutical Analysis C, and this college recording resembles Chapter 9 in your syllabus. It is given by Janneke Dijk-Brouwer, working at the Department of Laboratory Medicine in the University Medical Center Groningen. The recording is 3 hours, 3 college hours of clinical chemistry. It does not contain a lecture that is given by Martijn van Vaassen, because it's not necessary to learn that for your examination. After this morning or this session, you are able to understand the role of the clinical chemical laboratory in diagnosis and follow-up of patients. You are able to describe the sources of variation in clinical chemistry and to answer the question whether a test outcome is normal or abnormal using reference ranges and cutoff values, taking into account the sources of variation. You are also able to understand and describe the establishment of reference values and cutoff values, including their advantages and disadvantages. You should be able to use and to apply the Bayes theorem in diagnostic accuracy and calculate, understand and interpret the parameters of diagnostic accuracy. Last but not least, you will be able to describe and use factors that influence the interpretation of laboratory results in the follow-up of patients. The outline of this recording is an introduction into clinical chemistry, and later on we try to answer the main questions in clinical chemistry, which are actually diagnosis and follow-up using clinical chemistry parameters. For diagnosis, the most important question is the outcome normal or abnormal? And this can be answered by comparing the outcome with reference ranges, with a consensus cutoff value for diagnosis, or the consensus cutoff value that is used with using the Bayes theorem. So this means number C, the outcome is consistent with a laboratory diagnosis of a particular disease. The second important question is the follow-up of patients, and then we have two main questions. Is the outcome different from the previous one, or is the outcome below or above a consensus treatment goal? For the answering of these questions, we need information on analytical variation, biological variation, and of course the influence of pathology on lab results. I would first like to introduce you to the scope of clinical chemistry and the samples and tests that we use, also indications for test, its place in diagnosis. We would like to show you the scope of clinical chemistry in a small movie, which comprises a visit of a patient to a doctor, a blood sampling, a clinical part, and we all show you the sites where clinical chemistry is important. The scope of clinical chemistry is shown on the cases of cystic fibrosis, a very severe disease that is screened for in the newborn screening in the Netherlands, but clinical chemistry plays an important role in the diagnosis and follow-up of those patients. We talk about the quality of clinical chemistry, the sources of variation, which comprise analytical variation, biological variation, and for analytical variation we use quality control. And we show you the desired relationship between analytical and biological variation. And this is also important for the determination of the index of individuality. What is clinical chemistry? It's analytical chemistry for medical purposes, and that means that it's applied in hospitals, but also in the general practitioner's practice, but also in other forms of healthcare, but also public health. The objective is to answer a clinical question by the use of biological material that is deriving from patients or people that may be considered as patients. its scope is broad, and that means that the field is broad. It ranges from hematology to endocrinology, but also very basic and very widespread used techniques, and fields of application from internal medical applications to surgery, internal also intensive care units, and many more. We have over 700 different analytes that are measured, so the scope is very broad and the applications are wide. There are many analytical techniques ranging from rather simple spectroscopy to mass spectrometry, flow cytometry, and many more. The turnaround times, and this means the time that it takes to give an answer to the question, also, or to, in other words, to the reporting time of the outcome of a test, those range from minutes to weeks. Minutes are found at point of care testing, at patient side, bedside testing, but also an hour in the routine clinical chemistry and hematological laboratories. But sometimes a doctor has to wait weeks before the answer to the question is given, and this is because, of course, that it's not necessary to give the answer right now, immediately, but also it has to deal with the analytical techniques that are used that can be very time consuming and people consuming, or work consuming, and also very expensive. The samples that are used in clinical chemistry are most times blood and deriving from blood, plasma and serum. I guess it's about 90% of samples that derive from blood, and the other 10% consist of urine, feces, cerebrospinal fluid, amniotic fluid, semen, sweat, tears, and some more. As said, we most times use blood samples in clinical chemistry. Blood can be leaving to clot, and then when we centrifuge it, it is separated into serum and a blood clot. The serum can be used for measurements, but when the blood is not clotted, it's separated into plasma, white blood cells and platelets, and red blood cells. That all can be used for different analysis. As you can see, there's also different kinds of additives to tubes, and they are all have a certain reason. For example, citrate, which binds calcium, but also not in a very strict manner, and that means that after addition of calcium to the tube in a coagulation assay, after adding the calcium to the tube or to the analytical method, it is possible to measure coagulation activity which occurs in vivo in a patient. As said, blood can be clotted, and for that we have serum tubes, and for that we use it for hormones and vitamins. In routine clinical chemistry we use the heparin anticoagulated tubes because it is then not necessary to have the tubes clotting, which takes about 20 minutes at least. So this means speeding up the process, and that makes it easier to report data within an hour. We also have tubes containing EDTA, which strongly binds to calcium, and that means that there's no clotting at all anymore. And last but not least, we have the fluoride oxalate anticoagulating tubes, which are used for stabilization of glucose, because the glycolysis is inhibited by fluoride. When we check out the top 5 and 20 of clinical chemical tests that are ordered by general practitioners, we see that the determination of whether there's an infection or not is very important for them, and those are measured by measuring the erythrocyte sedimentation rate and C-reactive protein. They both change upon infection, but also, and that is most possibly because many patients report tiredness with a GP, and for that there can be an anemia which is diagnosed based on the hemoglobin level. It can also be diabetes, which is diagnosed using plasma glucose, and there can also be a thyroid problem, most likely hypothyroidism, which can be diagnosed using the thyroid stimulating hormone. After that top 5, we have a top 20, which includes more detailed examination of anemia causes, which can be, for example, measured by differential analysis of the parameters of erythrocytes, but also kidney function, which is measured by creatinine and the derived glomerular filtration rate, liver function, which can be determined using the alanine aminotransferase and the aspartate aminotransferase levels, which all increase with liver damage. And also cardiovascular risk can be established using triglycerides, high-density lipoprotein cholesterol, and low-density lipoprotein cholesterol. When we check out the routine laboratories in a clinical chemical or within a hospital, we see that there's a hematology and a chemistry department. And as I told you before, hemoglobin is very widely used to detect anemia because hemoglobin is important in the oxygen carrying capacity of the blood. The red blood cell indices, as told, are important in the differentiation of the anemia. For example, big cells indicate vitamin B12 or folic acid deficiency, but small cells indicate iron deficiency or other causes, for example, alpha thalassemia or sickle cell anemia. White blood cell counts are used to determine whether there's an infection or not, and if the differential count is used, there's a distinguishment between infections, allergies, etc., because in those conditions the proportions of the different types of white blood cells differ. Platelets are very important in blood clotting, so the platelet count is important in blood clotting processes, but more important also are the coagulation assays, just like the INR, bleeding time, proton time, and others. In chemistry, glucose is used to diagnose diabetes mellitus. Electrolytes such as potassium and sodium are used for the fluid and blood pressure balance, and they are essential for most body system functioning. Enzymes are used for heart and liver damage and diseases, for example creatine kinase, lactate dehydrogenase, aspartate transaminase, and alanine transaminase. Cholesterol, for example, is used for the establishment of the cardiovascular disease risk. Albumin and total protein are mainly used for determination of liver function instead of liver damage, but low albumin and low protein can also indicate severe kidney disease or malnutrition. Creatinine and urea are used to determine kidney function, and from the creatinine there's a calculation including age, etc., of the patient to calculate kidney function, and which is depicted as the glomerular filtration rate. And the last one is uric acid, which is used as a marker for gout. The most important lab test indications are to diagnose a patient. Sometimes there's profiling, we call it shooting in the dark. There's no indication, there's no clinical sign of a disease. Profiling is, for example, used in preoperative screening because the outcome of, for example, diabetes, thyroid disease is very important in the outcome of surgery. And for this reason, there is screening on diabetes, hypothyroidism, but also anemia and clotting problems in profiling. So there's a use, but there's also a risk on it, which we come back to later on. There's various reasons for follow-up of patients and then lab test indications. It can be either wait and see. For example, there is a slightly elevated or slightly changed lab result, which does not mean direct disease, but maybe a higher risk of disease. There's no direct treatment necessity, but it can be useful just to follow up those patients. Another reason for follow-up is to check whether a treatment goal is reached or whether there's indeed improvement of the disease or the condition. Another test indication is case finding. For example, there's a very obese patient coming to the GP with a sore finger or whatever, and at that time a GP may indicate glucose testing because in very obese, especially in elderly patients, the risk of diabetes is high. Screening as the last test indication, it is a special case, and screening is only performed when early detection of a subclinical condition improves the outcome of the patient. As this slide tells you, the most frequent indication for a lab test is diagnosis, and we can also see that therapy follow-up is very important. Despite we discourage profiling is a major proportion of the lab test indications, but there is reasons to do profiling in some cases. Very close to therapy follow-up is at least that the previous test result is abnormal. This means also follow-up, which as told before can be because there is a high risk and there was a small increase or decrease of the test outcome. Sometimes lab tests are used for prognosis of patients, which actually tells if the outcome is very deviant from normal values, the prognosis may be worse. Defensive medicine is increasing, and defensive medicine means that there is unnecessary lab tests, either to reduce adverse outcomes, to deter patients from filing medical malpractice claims, to provide evidence that the practitioner is practicing according to standard care, and all is to reduce the risk of claims. And here we see that in the USA, in 18% of lab tests, they are ordered for defensive reasons. What does a lab test aid in the diagnosis? Please remind that almost no diagnosis can be set based on only laboratory medicine tests. Patient history, physical examination, and the total of anamnesis are the cornerstone of a differential diagnosis and hypothesis. Lab tests, imaging techniques and other measures are used to support or reject this hypothesis or diagnosis. So all the patient data are at least as important as the results of lab tests. There's a small movie on the way of working of laboratory medicine that you can find also on Nestor. It deals with a patient with cystic fibrosis. The cause of cystic fibrosis is a defect in the cystic fibrosis transmembrane conductance regulator, the CFTR. It is an important protein in chloride ion transport in cell membranes. This transporter is involved in the production of sweat, digestive fluids and mucus, and when it's not functional, secretions, which are usually thin, become thick. The symptoms of cystic fibrosis patients are difficulty in breathing and coughing up sputum, frequent lung infections because of the thick mucus, sinus infections, poor growth, fatty stool, infertility in males and many others. The infections are found mainly in lungs and upper respiratory tract, and they lead in the end to transplantation of the lungs. Pancreatic insufficiency is shown in diabetes mellitus risk. Malabsorption is found in poor growth and vitamin deficiencies, notably the fat-soluble vitamins, and related to the poor absorption of vitamin D, there's also osteoporosis. As screening improves prognosis, it is added to the newborn screening in the Netherlands. After screening, the diagnosis is based on sweat testing and possibly genetic analysis. CF is a part of the screening and it's based on a decision tree which includes immune reactive trypsinogen, or IRT, which is a pancreatic enzyme, but it's not specific for cystic fibrosis. The second parameter that is used is the pancreatitis associated protein, or PAP, also a pancreatic enzyme which is produced in stress, but it's not specific for cystic fibrosis. When either one or two of those is elevated, there's DNA analysis. First there's analysis of known CF mutations and whether they do not explain the increased IRT or PAP, then there's sequencing, which is a screening for new or low frequent mutations. After confirmation, there's a sweat chloride measurement to confirm the diagnosis of CF. In this slide we see the decision tree that is used. It starts with the measurement of IRT, and when it's normal, which is below 60, the test is considered negative. When it's elevated, the PAP is measured, and when it's this is elevated as well, there's another decision tree based on the outcomes of both the IRT and the PAP. And when this results in a positive outcome of CF risk, DNA analysis is performed. When there is an elevation of IRT and PAP and there's either 0 mutations or 1 or 2 mutations, there's a different strategy, and when there's only 1 mutation, then extensive genomic analysis is performed, and also based on the outcomes of this, there's either a normal or an abnormal outcome. We showed in the movie Christine Franson. She has CF, and the follow-up lab tests for clinical chemistry for Christine are the follow-up of infection, and for this we use the C-reactive protein, the erythrocyte sedimentation rate, and the white blood cell count. For nutrient deficiencies, we use the measurement of status of vitamin D, E, A, and K, and for the establishment of diabetes, we use glucose and glycosylated hemoglobin. As you see in the movie, quality in clinical chemistry is both diagnostic quality, or how good is this test for the determination of a disease, but also turnaround time and acceptable costs. In the movie, it was visible that the turnaround time for the infection parameters is relatively quickly. So this means within an hour after the blood sampling, the results are given. It should be noted that quick and good clinical chemistry tests are quite expensive, and in this period of limited resources for healthcare, the cost should be acceptable. We therefore think that high speed, low cost and high quality tests cannot always come together in utopia, but please remind that high speed comes together with sometimes lower quality or expensive tests. So there should be a kind of optimum between speed, cost and quality, in which of course the clinical need of the test is very important. You don't want to wait hours and hours for the measurement of a life-threatening parameter. Quality is very important, and this means that actually we apply evidence-based laboratory medicine. When a new test is introduced into the clinic, the main questions are: does the test improve patient outcome as compared to an existing test? Does it impact on the clinical decisions and improve the diagnosis? And is the benefit economically? Most times we at least evaluate the test based on a technical quality and diagnostic accuracy. But actually, a new test should also change the diagnostic thinking, patient management, patient outcomes, and lower societal costs and benefits. At least number 1 and 2, the technical and diagnostical accuracy, are very well known, but the other parts are very often neglected. What is important in diagnostic quality in clinical chemistry is actually divided into 3 parts. Analytical factors, meaning accuracy or bias, which is a deviation from the true value, and precision. Biological factors that are very important include intra and inter-individual variation. Intra-individual variation means the variation within a subject, whereas inter-individual variation means the variation between subjects. And also the last one is pathophysiology factors, and that is the influence of the disease on the test outcome. And preferable, there's a huge influence on the test outcome in order to give a good separation between the results of patients and controls. However, most times there is an overlap between the outcomes of healthy and diseased patients, which is shown in this slide. The ideal test shows a distinct separation between the results of healthy and diseased patients. However, the practice is different, and that means that there's always an overlap between health and disease, and it means that there's always the chance of false positive and false negative disease test outcomes. And this means that there's always a problem. When we check out the sources of variation, we also talked about analytical variation. Accuracy is do we measure the right value, which is very difficult in clinical chemistry, especially when hormones are measured. because it's very difficult to establish the true value. Imprecision is also very important, and this is shown as intra and inter-assay variation. As said, the biological variation is divided into intra and inter-individual variation, but it should be noted that the pathophysiological variation is influenced by the stage of disease, the differences in disease presentation, comorbidity, etc. How can we reduce the influence of variation? If we reduce the bias and imprecision, we can reduce the analytical variation. Biological variation reduction is a bit more difficult. It can be performed by standardization of sampling procedures, the metabolic state, for example for glucose and triglycerides, we measure them in a fasting state, and it is also very important to compare them with the appropriate subgroup of controls, for example of the same age and same gender. For this we also apply gender different reference ranges for males and females, and also sometimes post and pre-menopausal data for some hormones that are important in fertility. How can we reduce the pathophysiological variation? Just by applying wait and see, or by augmentation of differences, and for this we use loading tests or stimulation or provocation tests. For example, the glucose tolerance test, in which a very high dose of glucose, 75 grams of glucose, is given to a patient and glucose is measured 2 hours afterwards. When we look at analytical variation, we have two important parameters, and those are accuracy and precision. Accuracy is how well a measurement agrees with an accepted value, whereas precision means how well is a series of measurements in agreement with each other. As I told you, it's very difficult to measure accuracy because it's in clinical chemistry there's no real in clinical chemistry it's difficult to establish accuracy because we have to deal with a complex matrix with, for example, hormones, and for those it's difficult to measure how its exact value is because of the techniques that we use. Analytical variation and accuracy and precision can be resembled by duck shooting. The perfect test is in the upper left quarter, which means high accuracy and high precision. And you can we all agree that a test with a low accuracy and low precision is a bad test. But how to choose between a test of high accuracy and low precision or a test with low accuracy and high precision? Well, if we consider the fact that in clinical chemistry only 1 or 2 measurements are performed, a test with low precision is not a good idea. Although you find the mean of all those results at the right spot, there is still a lot of variation when you only choose 1 or 2 measurements. Is then the correct answer, where is it? It's difficult. So for that we prefer a test with a low accuracy and high precision above a test with high accuracy and low precision, because the bias that is based on the low accuracy can be corrected using a kind of computer program. Precision is actually also 2 different parameters. It is repeatability, which means the closeness of agreement between the results of successive measurements of the same analyte and carried out under the same conditions of measurements. And reproducibility is the closeness of agreement between the results of measurement of the same analyte and carried out under changed conditions of measurement. And actually, reproducibility is what we mean by precision in clinical chemistry, because most times we measure things twice at separate times. Also separate, different technicians, maybe different conditions, at least at different times. And to guarantee that we have a good precision, we use internal quality control, which means that if we measure a potassium on Monday and we measure it again on Friday, we have the same result. For this, and to monitor the variability or the precision of our methods, we use the Levi-Jennings plots. And we have actually 3 deviations from what is okay. In panel A you see dispersion. That means a huge variation, and sometimes it is outside the ranges that we think is okay. Possible causes can be air bubbles or clots in the cups, or in reagent tubes, insufficient mixing or imprecise pipetters. In panel B we see a trend in the outcomes and a very slow deviation from the mean. This can be a change in ambient temperature, lower intensity of the light source to measure the outcome, or a reduced stability of the reagents or controls. In panel C we see a shift, an immediate change of the outcomes of the internal quality control outcomes, and this can be caused by a new reagent or a calibrator lot, or incorrect calibrator values, reagents or reagent volumes. On the other hand, we have an external quality control or a proficiency testing. And this is not a measurement of precision, but a measurement of accuracy. And the accuracy is derived from analysis using a reference method, which is either the gold standard or the state-of-art analysis method, in other words, the best available. And as stated, there's no absolute value in clinical chemistry for most analytes because of the matrix of blood and also the nature of the samples that we use. This means that we most times have a kind of consensus value, which is the overall mean of all results provided by the laboratories. The goal of external quality control or proficiency testing is minimizing differences between laboratories, and in your syllabus there's a nice example which uses glycosylated hemoglobin standardization to show that after standardization there is less difference between laboratories. So it leads to harmonization of test results and, as a consequence of that, reference values. In this example we see the result of the vitamin D, 25-hydroxyvitamin D external quality controls for different laboratories in the Netherlands. This is performed by the SKML, the Stichting Kwaliteitsbewaking Medische Laboratoriumdiagnostiek. They send one sample to different laboratories, and those laboratories use different methods. For example, automated methods as confirmed by Abbott or Roche, but also HPLC, LCMS, MS, etc. If you see the graph, you see on the x-axis the reported concentration of 25-hydroxyvitamin D, and on the y-axis the number of results that was presented by different laboratories. First of all, we notice a huge spread of all the outcomes of one sample. This means that there is a range from 70 to 110 nanomoles per liter. We are quite in the upper part with a outcome of 101. And what you also see is that there's a huge variation in the techniques that is used. For example, the yellow bars are LCMSMS. However, they do not result in comparable results of the 25-hydroxyvitamin D. There's a range from about 80 to about 100 using the same kind of method. And also the Roche analysis way, which is automated, fully automated in a clinical laboratory, there's a huge range in all the results. And actually there should be no range at all. So this means this graph shows that there's huge variation, and this is difficult because there is cutoff values to represent an optimal vitamin D status. Well, we talked about analytical variation, we talked about accuracy and precision, and intra and inter-assay variation. But more important in clinical chemistry is the biological variation. And then we talk about intra and inter-individual variation. This graph shows the differences between inter and intra-individual variation. On the left part panel we see the immunoglobulin M as a function of time in 10 healthy subjects. And we see that in most subjects it's very stable. That means a low intra-individual variation. However, when we check out subject B to I, we see a lot of variation. The range is between 200 and 1600 milligrams per liter. This means that the inter-individual variation is a lot higher. Subject A might be a kind of subclinical condition because the outcomes of the IgM are elevated as compared with the outcomes of all the other subjects. The left panel shows a small intra-individual variation and a huge inter-individual variation. The right panel is on homocysteine in subjects, and for this we not only see quite some inter-individual variation, but also a quite high intra-individual variation. The relationship between the intra and inter-individual variation is depicted in the index of individuality. The index of individuality reflects whether a test is useful for diagnosis or for monitoring. It is calculated by dividing the within intra-individual variation by the inter-individual variation, which is the between subject variation. When intra-individual variation is low as compared to the between subject variation, a test is better for monitoring, because a small change in a patient or in a subject tells us more than a deviation from, for example, the reference value. So when an index of individuality is below 0.6, it is better for monitoring. When the within subject or intra-individual variation is relatively high as compared to the inter-individual variation, then the test is better for diagnosing subjects. So if the index of individuality is above 0.6, it's better for diagnosing. We showed two examples to show you this. The first is troponin and the second is CRP. Troponin is part of the myocardium, and when the myocardium, for example by obstruction, which is a myocardial infarction, is damaged, troponin is released into the blood. So myocardial infarction is diagnosed by elevated troponin values. So myocardial infarction is diagnosed by the finding of either a single cardiac troponin value above the 99th percentile of a healthy subject, But more important, we use a significant time-dependent change in cardiac troponin concentration, and for this we use an interval of at least 90 minutes, but preferable 6 hours. It should be noted that dialysis patients have a high risk of myocardial infarction, but also an increased troponin level without having a myocardial infarction, and this is because of the reduced renal clearance of troponin. And this is shown in these graphs. The left panel shows troponin concentrations in healthy individuals. Also we see two values, which is the range between the two values within one subject. What we see is that most times the variation within a subject is very low. There is some change, for example over here, but it is relatively small. The between subject variation is rather high. The range is from about 3 to almost 15 nanograms per liter. When we check out dialysis patients, then it should be noted that the range of the y-axis is much higher than in healthy individuals, without them having a myocardial infarction. So this is the first sign that the reference values are difficult to use here. What we see that within a subject there is small variation, but there's a huge between subject variation. This is also calculated. We see that in hemodialysis patients, indeed the concentration of troponin, and it depends on the form of troponin that can be used, troponin T or troponin I, but both are much higher in dialysis patients as compared with individuals that are healthy. And if we check out the individual variation, the intra-individual variation, then we see that it is low in both hemodialysis patients and healthy patients, subjects. The between subject variation is much higher, and this results in very low index of individuality, which is 0.02 in dialysis patients and 0.3 in healthy individuals. In both groups, the index of individuality is below 0.6. This leads to the conclusion that the low index of individuality in troponin of both healthy subjects and dialysis patients suggests that the use of a diagnostic cutoff value can be omitted, and it's more sensible to monitor troponin for the diagnosis of myocardial infarction. And this is actually clinical practice. This theory is also centered about a patient with cystic fibrosis, and one of the main issues of cystic fibrosis is infection in the lungs. For infection we have three parameters: white blood cells, CRP, and the erythrocyte sedimentation rate, in which the CRP is very sensitive. Also for CRP we can ask the question whether it's useful in monitoring or diagnosis, and for this we see about the same as in troponin for myocardial infarction. We see the distribution in the left panel of CRP concentration in apparently healthy blood donors. There's a huge spread from about 0.08 to 3.29. And if you include healthy subjects for 6 months in a study in which on several occasions the CRP is measured, we see that there is considerable between subject variation and relatively low within subject variation, with some exclusions of this. This table not only shows the variation coefficients for CRP but also for cholesterol. But if we calculate the index of individuality, we see in this study for CRP an index of individuality of 0.46. However, in other studies, an index of individuality of 0.83 was found, and this is rather strange. The authors concluded that in their studies for CRP measurement used in conjunction with a CRP reference interval is less than optimal for use in diagnosis, especially in early disease. So it means that many individuals can have early disease-associated changes that do not exceed the reference interval. So CRP is more useful in monitoring as compared to diagnosis. Biological variation determines the quality of a test. There is a criterion for the precision in diagnostic tests, which is determined by biological variation. When we, for example, consider serum sodium, which is very tightly regulated, you can imagine that a small change in serum sodium has very huge consequences, for example, rhythm disturbances or other functioning that are maybe life-threatening. This means tight regulation means a small biological variation. If we then apply a test with a high analytical variation, it is very difficult to determine whether a change in value is either caused by a analytical variation or by a change in physiology or pathophysiology. So that means that an analyte with a small biological or intra-individual variation needs a test with small analytical variation. This means that in this case, the analytical variation is too high. Sometimes we see analytes with a high biological variation, for example cholesterol. Then it's very nice to have a low analytical variation, but it's not necessary. There should be an optimum, and the quality control aim is that the inter-assay variation is at most 0.5 the mean intra-individual variation. And for this the criterion comprises the inter-assay variation, because most times if you want to detect a change within a subject, within a patient for example, we need the intra-individual variation because it deals on a change within a subject, but this change is measured on two separate occasions, not within one assay. So that means that we need to be very strict on the inter-assay variation coefficient. Well, we know a lot about biological variation and analytical variation. For many analytes it's known what the biological variation is, both with intra-individual variation as inter-individual variation. Also the imprecision and the bias are known, and that means that we can also calculate the total error budget. This is all shown in the Westcard database, which can be found on the Westcard site. This brings us to the end of the first part of this lecture.